Cardiovascular Risk Reduction Program at Grady Health System. He is the past president of the the National Lipid Association, and the chair currently of the recommendation panel, and actually is on the expert panel for many different organizations around lipid management. And so he told me to make my introduction brief. I could go on because he has lots to share with you. I'm very excited to introduce you and welcome Terry Jacobson.
Thank you, Jada. Thank you, everyone, for coming today and making it through the rain. I see we have a packed crowd on a hot topic. I haven't been to Grand Rounds in a long time, and it's good to be back again. I'm going to talk about beyond statins. It's hard to envision a world beyond them because they have been one of the most effective therapies that we've had in cardiovascular prevention. And then I'm going to talk about new therapies, new targets, new treatments, and even beg the question, can we actually reverse atherosclerosis by taking out the inciting ApoB lipoproteins that are the nidus of initiation of atherosclerosis? So these are my objectives for today, and I'm going to go very fast. I have more slides than I thought when I put this together this morning. I probably should have done it yesterday, but it was Memorial Day weekend. I'm going to review the evidence base of statins, and I think you all should know this fairly cold. This is very important. It's probably the most well-studied intervention that we have in medicine today. And then I'm going to talk about non-statin therapy, what's new. Do non-statins on top of a statin reduce cardiovascular risk? Then I'm going to talk about guidelines, a very contentious thing that I got in the middle of, and I'll share with you that in a second. And then just talk about future targets. And I'd just say the future is very bright in cardiovascular medicine. Genetics are exploding every day. I was just talking earlier in the New England Journal this week, another study with a gene marker showing an decreased risk of MI, and really pointing the way where our future targets will be. So I'm going to start off with a case, a typical patient that we all see, a 54-year-old female, history of hypertension, diabetes, and STEMI, recent PCI incident 6 weeks ago, who comes to see you for routine follow-up. The vitals are pretty normal. She has corneal arcus. Her BMI is elevated. She's on some good medicines, including metformin, amlodipine, losartan, diuretic, clopidogrel, atorvastatin 80. Her labs, you could see below. I'm going to show you on the next page if you can't read it. But generally, so this lady's had a lot of events, and she's on optimal therapy. If one looks at her lipids, her LDL is 128. Her trigs are elevated at 180, HDL is 48, non-HDL is 164. Her glucose and glycosylated hemoglobin are pretty good. She is a diabetic. So the question is, what do we do for a patient like this who comes in on fairly optimal ASCVD therapy? She's on a statin, high-intensity statin. Her LDL is only 128. Are we satisfied or not? Is there evidence today that intervening with a lipid-lowering agent could actually make a difference in this lady? Let's see. So I'm going to first go over the evidence for statins, but I want to first give you a few quotes about statins. Scott Grady, who is the author of the NCEP guideline 3 and 1 and 2, actually 2 and 3, he called statins one of the greatest discoveries in the history of modern medicine. And if you know Scott Grady, he's a pretty modest guy. He doesn't make these exaggerated statements. And then one professor, Simon, said, statins are to cardiovascular disease what penicillin is to infectious disease. They're the most important, if not the most important, advances in cardiovascular medicine. And then finally concluding with a quote by Brown and Goldstein, who won the Nobel laureate for the LDL receptor, saying that this contribution will really extend the lives of millions of patients and is a major advance in therapy. This is Brown and Goldstein at a younger age. They characterize the LDL receptor I met both of them. One day I was in an AHA meeting, and the guy next to me struck up a conversation. We're just talking, and he says, "What do you do?" I'm saying, "I'm down at Grady, I'm in the trenches." And I said, "Well, what do you do?" He says, "I'm in the lab in the trenches as well." I said, "What kind of stuff do you do in the lab?" He says, "Yeah, it's kind of like cholesterol and stuff like that." And I said, "Where are you?" And he said, "Dallas Southwestern." I said, "Do you know Scott Grady?" He says, "Sure." And I said, "Do you know Brown and Goldstein?" He says, "I'm Brown." I was like so embarrassed because I didn't recognize him, and I couldn't pay attention to the lecture the whole time after that. Saying, "Oh God, did I say anything ridiculous?" Okay, everyone knows this pathway, and they told me for Grand Rounds to do very little basic science, even though I want to. I've tried to resist as much as I could, but this is pretty simple. Cholesterol is made from acetyl coenzyme A. The rate-limiting enzyme for the conversion to cholesterol is 3-hydroxy-3-methylglutaryl coenzyme A. So this is the rate-limiting step of cholesterol synthesis. So if you can impede it early on, you can block this pathway. The problem is you need cholesterol for a lot of things. You need them for steroid hormones, you need them for myelin sheaths, you need them for bile acids. So you can't block it totally. And the question becomes, how much cholesterol do you really need in the body to make your basic biologic functions? Several drugs have been developed later on in this pathway, like squalene synthesis inhibitors, that turned out to be toxic. And so one has to be very careful where one intervenes on this pathway. But this is the basic science, and this is really going on mainly in the liver, where it has the majority of the body's LDL receptors. And so what statins do by inhibiting the production of cholesterol in the liver, they upregulate LDL receptors. More LDL receptors, more LDL is coming back into the liver for degradation. LDL levels are plummeting in the blood. All of you know all the landmark statin trials. I'm not going to go into them other than to show a few things for historical interest. The FOURIER study, their baseline LDL was 188. It's the first study to show that total mortality was reduced with this statin. I think this got a lot of naysayers finally believing in the lipid and statin hypothesis. To all the way in the bottom, the Jupiter trial, the mean LDL was 108. We would call that fairly normal. All these folks did have elevated CRP greater than 2, but in general, they had significant risk reduction of about 41%. And so the question is, what is the ideal LDL? Back then, less than 130 was felt to be desirable if you don't have heart disease. The suggestions are now it's way below 100. What is that exact number? No one knows. Now, the Cholesterol Treatment Trialist Initiative is a very interesting initiative in the UK. They take all the data of every statin study, pool it together, and this is over 170,000 patients, about 31 clinical trials of individual level patient data. With that data, you can do a lot, and they've done some amazing things, but this is the strongest evidence base for statins in general, and let's take a look at what it shows. So here's the first thing that it shows, and I just want to orient everyone to this. This is a confidence interval. Anything to the left of this line shows benefit. Anything crossing the line generally shows that it's not statistically significant. But in general, going down, looking at all these very potent statin studies of more statin versus less, as well as statin versus placebo control, show one overwhelming result, a 22% risk reduction per millimole LDL reduction. That's the Brits. 1 millimole is about 39 to 40 milligrams, but that implies that if one reduced it twice that amount, that the amount of risk reduction would be close to double. And so this is very powerful data in the largest database of statins that we have. I want you to take a look at the events that are actually reduced. Everything except one thing is to the left of the confidence interval, which is pretty amazing because usually you see stuff on both sides, but it shows the effect is so potent with a reduction in non-fatal MI, CHD death, all coronary events, revascularization procedures, ischemic stroke, even though cholesterol is not a major risk factor for stroke beyond what we would expect it to be. Interestingly, hemorrhagic stroke crosses the 1. And basically, although it looks like a slight uptick, it's still statistically insignificant. I think there has been a concern with statins, with hemorrhagic stroke over the years. It really hasn't panned out. It's been seen in a couple trials, 2 trials in particular. One was the SPARKLE trial in patients with post-stroke given atorvastatin, and also was seen in a dialysis population. But I would just say that the numbers are very tiny of hemorrhagic stroke compared to ischemic stroke, so I don't think this is a really significant finding. But overall, it just shows the power of the statins. And finally, if you look at everyone in this cohort by baseline risk, this is risk over 5 years, one thing that you see, and I find this fascinating, and there's a lot of implications, is that your risk, even if your risk is less than 5%, that's like super early primary prevention, your risk reduction was the same as if your risk was greater than 30%. In fact, when I look at this line, and maybe because I love statins and lipids, I extrapolate and say, hey, is that saying maybe starting earlier in the prevention process might yield better results than waiting to hear? The answer is we don't know. But I think what I'm going to tell you today from the genetics, it seems like earlier intervention is the way to go if one wants greater risk reduction. And so in this CTT analysis, not only did baseline risk, there was no threshold where people did not benefit, LDL levels as well. They had a tertile of less than 77. They all had the exact same benefit. And so what's curious, it doesn't matter where you are in the LDL curve, your relative risk reduction is exactly the same, no matter high risk or low risk. Your absolute risk reduction is different, though, and that's another issue. So those are the statins, and I would say clearly wonder drugs, put them in the water supply, whatever you want to do. Let's talk about the non-statins. You know, I was talking earlier about genetics and the revolution going on in it, and it's really cleared the path of new mechanisms of lowering LDL cholesterol and new mechanisms of ASCVD. And this is an enzyme called the Niemann-Pick C1L1 receptor. And what they found in a very large cohort, that patients who had this mutation had 12 milligrams lower LDL over a lifetime and were found to have an odds ratio of 0.47. So a lifetime of having this mutation, an activation of the mutation, showed a fairly significant risk reduction greater than one would see with a statin. And this was actually put into therapy. Ezetimibe was a drug that was created that targets the MPC1L1 receptor. It upregulates 8 LDL receptors, one of the most important mechanisms, also decreases the cholesterol content of atherogenic particles. It's not systematically absorbed. And so let's get to the first trial. And there's been several other trials with ezetimibe, but I want to concentrate on this one because this is the most important. So the real question is, can one beat a statin? And I would argue it is very hard to beat a statin, particularly a high-intensity statin. It's very hard to beat optimal cardiovascular therapy to make incremental gains. So this study, which was actually a very long study because they were having trouble getting events given that prevention is going so well, they took 18,000 patients, randomized with ACS less than 10 days to either simvastatin 40 or ezetimibe simvastatin 1040, followed them 30 days and then every 4 months, an event-driven trial, 2.5 years to get 5,250 events. It turned out, even though this is an ACS trial, it took a long time for them to get this many events, and basically there was a lot of loss to follow-up, a major criticism in the trial. What do the patients look like in the trial? They're generally middle-aged, About a third had diabetes. About 21% had an MI prior to the ACS. Most of them were 5 days out after ACS. About a third got lipid-lowering treatment. Their baseline LDL prior to treatment was 95. So in given the therapy, what happened? So 95 in the ezetimibe and simvastatin group went down to 53.7, very good. And the simvastatin group went down to 69.5. Back then, LDL goals for CHD patients was considered less than 100. So going below goals, is there data that an additional LDL reduction will reduce risk? That effectively is what this trial asked. And lo and behold, there was a significant risk reduction. The NNT was 50 over 7 years, and that's important because it's a long trial. Now, a lot of people quibbled over the fact that the risk reduction seemed tiny. It was about 6.4%, and you'll say, is that worth it? When I show you the events that are reduced, you'll say, yes, I think it's worth it, with the caveat that a lot of people dropped out of this trial over the 7 years. When they do a on-treatment analysis, the risk reduction is even greater. But let me just show you the events that are reduced. And again, here's our wonderful confidence interval of 1. Let's start off with death. No change. CVD death, no change. MI, a definite risk reduction of 13%. Stroke, a definite risk reduction of 14%, most of it ischemic stroke. So I would say that in general, these are hard outcomes. These are easy to validate and adjudicate versus softer outcomes like unstable angina readmissions. So in general, this trial showed a small reduction in events on optimal statin therapy. Not everyone was on high-intensity therapy because that guideline came out later, but the majority were on either 40 or 80 of simvastatin. And just some more subgroup analysis. I just want to show you 2 groups seem to benefit the most, and those were the elderly, people above age 65, and also patients with no diabetes. And so in general, actually, I thought this was different. I actually thought the diabetics benefited. I'm looking at the slide again after many years. I'll have to research that. But in general, pretty positive data. Safety. What about getting LDL too low? Is there a problem? Here's some sub-analysis looking by breakdown of LDL achieved by 30, 50, 70. There is no increased events, period. And so in general, safety, no additional myalgia, LFT abnormalities, memory impairment, hemorrhagic stroke, etc., all the things that people worry about, a very positive study. And this study fits on the CTT analysis, the cholesterol treatment trialist analysis, right on the line of 1. So even though it reduced LDL by about 12 milligrams, the risk reduction is exactly as what would be predicted if a statin was used and reduced LDL by this amount. And so it seems consistent with the LDL hypothesis. Let's move on to the PCSK9 inhibitors, and that's a mouthful. I'll say it once, and I can't say it again. It's proprotein convertase septilysin kexin 9 inhibitors, or PCSK9 inhibitors. This has been a revolution in the field of lipids, and it all started with several early genetic observations. Here's a study done by Jonathan Cohn and Helen Hobbs in Dallas. They looked at people with mutations and found that certain patients had this PCSK9 mutation where their LDL was 28% lower than other people without the mutation. And then they looked at cohort data, and they found 88% of those patients, the risk reduction was fairly significant, 88%. And so a small drop in LDL over a lifetime is translating into very high risk reduction. And so it also begs the question again, is starting earlier with LDL, whether genetic or pharmacologic treatment, is better instead of waiting for an event? But this initial data finding cohorts with very low levels of LDL were very interesting. They found some patients with LDLs of about 10 and 15. And they did a lot of analysis to see, like, can they reproduce? Are they normal mentally? And they're all fine. So it shows you can have an LDL that low and still have normal functioning and reduced ASCVD risk. And this is just more genetic data of these loss of function mutations, risk of MI from many trials. And this pooled analysis suggests a 60% lifetime risk reduction. Contrast that with a 30% risk reduction with statins. Probably what's driving all the good stuff with different lipid-lowering agents is the LDL receptor. It is the ultimate nidus for how LDL effects are translated, and statins, bile acids, cholesterol absorption inhibitors, although they're working in the gut, they upregulate LDL receptors. And finally, PCSK9 therapy, which will show you what the mechanism is, actually acting at the level of LDL receptor degradation. So here's kind of a cartoon that shows a liver cell. I'm going to just start off real simply. That is a lipoprotein. That is an LDL receptor. This is a PCSK9 molecule. Generally, an LDL particle goes to the LDL receptor with the aid of a PCSK9 molecule, is then internalized into the liver for degradation. So it controls LDL receptor degradation. It's a protein or a protease that's secreted by the liver and other cells freely, and then it binds to the same site as the LDL receptor and the LDL particle, and then it, through endocytosis, it gets placed into a package for delivery to the liver, a lysosome, and then it's either degraded, and then the LDL receptor comes back up to, again, continue to get more LDL. And so anything that affects the degradation of LDL receptors will affect your LDL levels. And so if you can inhibit PCSK9, which is bringing LDL into the liver and into the cells for degradation, you will upregulate LDL receptors and get large decreases in LDL cholesterol. And the question is this really a viable therapy with monoclonal or other therapies to reduce PCSK9 and thus reduce LDL levels? And the answer is yes. And I just want to show you that in the initial trials of these agents, they lower on top of a statin LDL even more than a statin, 55 to 61% in all different types of patients. Think about that. I would never have thought, one, you could find anything that affects the LDL receptor other than a statin, but to get this kind of LDL reduction is unheard of because it's really targeting the ultimate, and that's the receptor, and the receptor degradation. And so very potent effects being achieved. Are there serious adverse effects with this treatment? To date, no. And the studies are fairly short. We only have data now out like 2 to 4 years. But right now, other than injection site issues, there's no other issues. And it's a monoclonal. It's injected every 2 weeks with a specific pen that's very easy to use, easier to use than insulin. I have patients who would prefer to do the pen instead of take their statin, and which kills me because it's taken so long to get people on evidence-based statin therapy. This is in addition to statin therapy and not a replacement. And so let me share with you some data with some of the PCSK9 studies. The first study I want to show you is an IVUS trial called Glaukoff. And Glaukoff with Steve Nissen took 970 patients, most of them on a statin, got evolocumab or placebo, followed for 78 weeks, And using IVUS looked at percent atheroma volume. And as you could see, very clearly in the statin evolocumab group, very large regression of lesions. The statin group had no progression, but clearly something major, but regression doesn't necessarily mean a reduction in events. But I want to just show you this one graph, which I find very interesting. And this is mean on treatment LDL and change in atheroma volume. In the past, we knew that lowering LDL down to 70 was very efficacious, down to 50. We never had data this low. And we now have data in the 20 to 30 range for the first time that keeps showing a linear relationship between regression of lesions. And so whether you believe regression is important or not, I think this is pretty phenomenal because it's showing exactly stuff at the vessel wall, and it's showing at levels of LDL we never thought were obtainable, and the relationship is still linear down to that level. So recently, the first PCSK9 trial safety analysis was published about a year or two ago. And this was a safety study, but of course people look at outcomes. And I'm just going to mention that in 2,341 patients, it was safe to use this PCSK9 inhibitor for 78 weeks, but they noticed a fairly significant risk reduction of about 48%. And this was in 78 weeks. And most people say, well, the number of events are small. And I agree, because a 50% risk reduction on top of a statin is pretty major. And I think this raised the bar and expectations that when the future long-term PCSK9 trials come out, the risk reduction would be even greater. And I think that, we need to temper those expectations with the designs of the trials. Again, in this same study, achieving LDL levels way below 25, no problem at all in terms of the classic side effects. Again, only for a year and a half of study, but these are looking incredibly safe other than the injection issues. There was concern about neurocognitive issues that has recently been addressed and put to bed, that these agents do not affect neurocognitive function. And it's the same with statins. Statins do not affect neurocognitive function, despite all your older patients telling you it causes memory loss. These are the FDA indications for PCSK9 inhibitor, and I'll just read it carefully. It's an adjunct to diet and maximally tolerated statin therapy. So you have to be on maximally tolerated statin therapy in the treatment of adults with heterozygous FH, that's genetic primary hypercholesterolemia. Most of those patients have LDLs greater than 190, have strong family history of heart disease or elevated LDL, or clinical ASCVD who require additional lowering of LDL. Evolocumab is also indicated for homozygous FH. Many of these patients, receptors don't work at all, so you might not have a response, period. And so it's a pretty heterogeneous group of patients, and just shows that they have data, and I'm sure the other one will have data in the right population. But in general, these are the current indications. Nothing about what your level of LDL should be in terms of whether you should get a treatment or not. So let's look at 3 major trials that have come out in the last year. Many of us in the lipid community have waited a long time for these trials because there's been so many negative lipid trials with other agents on top of a statin, particularly niacin, CETP inhibitors, fenofibrate, etc. They've not shown benefit on top of a statin. So let's talk about FOURIER, because this is the landmark trial that everyone needs to really understand in evaluating this class of drugs. So 27,564 high-risk, stable CHD patients. Most of them had either MI, stroke, or PAD. Most of them also had an additional risk factor or two as a kind of enhanced ASCVD population. screened on high or moderate intensity statin. If their LDL was above 70 or non-HDL above 100, they then either got the placebo injection or the evolocumab, and they were followed for 12 weeks. This was an event-driven trial, so whenever they got the number of events, the trial would be terminated. So let's look at the LDL reduction. LDL went from 90 to a baseline of 30. That is pretty hard to believe. And, I'm still always shocked when patients come back and their level is often 10, 20, 30. We can talk about whether to do anything about it, but very potent LDL reduction. What about the primary endpoint? The primary endpoint was an expanded endpoint of CVD death, MI, stroke, hospitalization. It showed a 15% risk reduction, about a 2% absolute risk reduction. This is at the 3-year period. The trial was stopped at 26 months because it met its endpoint. Now, do these curves continue to diverge? We'll never know because this trial was terminated like many positive studies early. Probably the most important endpoint, the hardest one of CVD death, MI, and stroke, showed a 20% risk reduction. Again, about a 2% absolute risk reduction, very favorable effects. Looking at subgroups, were there any particular groups that benefited over any other? And the answer is no. Everything, let's look at the secondary endpoint, to the left of this line generally shows benefit, including patients with LDL at baseline less than 80 or very high LDL. Again, this is the same thing we saw in CTT with the statins. It doesn't matter where your LDL is, you get the same fixed amount of risk reduction. So in general, a pretty positive study. This just shows a difference between the placebo group in blue and in red, the evolocumab group, clearly showing lower the better relationship down into the 20-30 range. One thing that these authors did is what's called a landmark analysis. They looked if the curves diverged more in the second year than the first year. Because this is a big part of the whole hypothesis that over time, risk reduction will get even better. So on the left is the first year, 16% risk reduction. On the right is year 1 to 2, and the risk reduction is 25%. So it does appear that the risk reduction is continuing to diverge, and we will see greater risk reduction over time, but all we know for now is up to this 3-year endpoint. In these 27,000 patients, any significant issues? And the answer really was no, other than injection site issues. A slight increase in diabetes, and we can talk about that later. They don't give a p-value for that. I calculated it wasn't statistically significant, but it's a big issue in statins and other therapy, and very few anti-neutralizing antibodies. So to summarize this trial, clearly inhibition of PCSK9 reduced major vascular events on top of optimal statin therapy. We now further validates the LDL hypothesis down to 20 to 25. In general, a lot of us think because of this, guidelines should change. Here's a very interesting PCSK9 study that was also published simultaneously in the New England Journal of the SPIRE study with bocazimab. This was a study that was terminated early because the effect of the agent started to wane in the first year. The LDL reduction initially was 50%, and over time it started to go down closer to 30-40%. Turned out these patients were developing an antibody, a neutralizing antibody to the PCSK9 molecule. And generally, the reason they developed it, this was not a fully human monoclonal antibody. This was humanized, still had like about, 5 to 10% urine products in it, but clearly people rejected this agent. But I want to share with you the results anyway, because there's some very fascinating things to learn in this SPIRE 1 and SPIRE 2 population. And just to make it short, SPIRE 1 took people with high risk on statins who had an LDL greater than 70. SPIRE 2 took those at high risk on statins with an LDL greater than 100. So SPIRE 2 generally is a higher risk population. Their mean LDL was about 130. In SPIRE 1, their mean LDL was about 100. Just want to show you what happened to the lipids in this study. As you could see, that all of a sudden, the lipids started to come back up. And because people were developing within the first year this neutralizing antibody, yet can we still look at their outcome data and make some conclusions? To make a long story short, SPIRE 1 in those with lower LDL did not have risk reduction. SPIRE 2 that had higher LDL greater than 100 did have significant risk reduction. And this is really at about an average of a year. So this is kind of additional evidence, and it was a 21% risk reduction in this study, that went just about a little more than a year. So in general, even though the LDL effect was waning, we still saw risk reduction. So it's supportive evidence of the concept of lower is better, PCSK9s will reduce risk. When you pool the two studies together, though, it just missed statistical significance by 0.07. So again, I think a positive confirmation. What can we conclude from these trials? Lower is better for sure. Longer duration of therapy is better. I think what we're learning from all these trials, that from the CTT and other and genetic analysis, the lower you can get people's LDL and the longer, the better for them. No signal with an LDL down to as low as 20. The absolute risk of the patient, the amount of LDL can still be used to predict the absolute benefit of therapy. Boy, these sound like great drugs. What's the problem? Cost. These are monoclonal antibodies, and these are expensive drugs. And so one of the reasons these drugs have not taken off on the shelves until recently is we didn't have outcomes data, but they cost $10,000 to $14,000 a year. Now, some of you are rheumatologists say that's nothing. Our drugs cost $80,000 to $100,000, et cetera. This is dirt cheap. But if you think about that, there might be 7 or 8 million people in the country with atherosclerosis, it becomes significant. So if one does formal cost-effectiveness analysis, and I'm no expert, the cost per year of life gain, what they call quality of life gain, is $300,000 to $2,000. Is that good or bad? That is not good. We generally consider $50,000 as the benchmark, which is dialysis. Now most of us consider $100,000 or less as something being cost-effective. So it's way off the scale because they've invested billions in these products to develop them. If one looks at $100,000 as what people are willing to pay for this kind of benefit, what should these drugs really cost? The answer is probably much less, and probably $5,000 to $7,000. It would make this drug class cost-effective. Now, there's so many rebates that go on between PBMs and healthcare plans that some might actually get this, but until we see better numbers, we have to use these drugs carefully, and those at the highest risk. Hopefully the economics one day will get worked out. I cannot say that for sure. The interesting thing down at Grady, I can get patients who have no insurance on a PCSK9. I can't get people with insurance on one. It is very interesting phenomenon just due to the way things are set up. So now I've showed you data that I think is pretty compelling, that lower is the better. We now have the means to do it. A word about guidelines. Which guideline is correct? And I would just say this, is that guidelines are just guidelines. They are a minimal standard of what to do. You know the patient, you know their history, you know their unique circumstances. When the ACC-AHA guideline came out, they had like 3 good things about it. And I say 3 because I've looked very hard to find some good things about it, because I've critiqued it and written about it and debated about it too many times already. But the identification of 4 statin benefit groups, I think, was the most ingenious part of it. People who clearly can benefit from a statin have ASCVD, LDL greater than 190. This was a very bold statement, And this is to identify people who might have familial hypercholesterolemia. The bottom line is, even if you don't have the genetics of familial hypercholesterolemia, if your LDL is in the 200, 300 range, you still are at tremendous risk. So that has become almost a CHD risk equivalent, with people with LDLs above 190 going on high-intensity statin. I'll just tell you one caveat is rule out secondary causes of high LDL, because you'll find them, and there are things like hypothyroidism, liver disease, renal disease, drugs, etc. Diabetes, primary prevention, definitely to use a statin. I disagree. I think all diabetics should be on a statin independent of their LDL, the same as CHD patients. Primary prevention, they encourage people to use the risk calculator, and if your risk was above a certain amount, 7.5%, to consider a statin and have a conversation of benefit and risk. I think statin intensity was a real good thing of the guidelines. Instead of saying start low and titrate, why not use higher intensity statins from the start, other than the fact that they have side effects? If you remember anything about this slide, you should know the two doses of high-intensity statin, atorva 40 and 80, Rezuva 20 and 40. And these are the doses that are meant to get a 50% LDL reduction, because that's what they do in short-term clinical trials. Do you get 50% LDL reduction in your general population? The answer is definitely not. And so most people will not, on a full-intensity statin, get to a goal level or get to a 50% LDL reduction. So when the ACC-AHA guidelines came out in 2013, everybody was fairly shocked, other than the guideline authors. And they concluded the following: we make no recommendation for or against LDL or non-HDL goals. They could not find randomized trial evidence, and because of that, they would not recommend it. They actually went further. They said they can't make a recommendation. They basically said don't do it. And so the whole concept of goals went out the window, and I think for the clinicians in this room, we all know how important goals are to both providers, to patients. It is the metric that people understand. I've had at least 5 or 6 debates with every panelist on the guidelines about why we need goals. I'm still arguing that. They still seem unconvinced. I think the newer data really suggests why, and it's because people have an inadequate LDL response to statins. Lower is better. The new clinical trial evidence with ezetimibe and PCSK9 now support lower is better on top of a statin. The new genetic data is totally supportive. Lower LDLs over a lifetime. Because of their recommendation, I happen to be president of the National Lipid Association at the time. I said, we need to do something about this. And everyone said, well, write your own guidelines. Saying I got a lot of other things to do right now than write my own guidelines. So we wrote recommendations, not guidelines, very different. But basically, we came back to the old goals of targets of less than 70, non-HDL less than 100. Many of you are not familiar with non-HDL, but it's simply subtracting HDL from total cholesterol. It's all your atherogenic lipoproteins. It is a better marker of risk than LDL. I think the future will have non-HDL in that. Of the people on the guidelines, I co-authored 2 papers with them prior on non-HDL. I thought it would be in the guidelines. They pretend they never wrote those papers. But I think they wanted to make a simple guideline, and they did. It was controversial. The ACC Expert Consensus panel felt that we need to do something about the AHA guidelines. Everyone's lost faith in the whole process. People aren't even measuring LDL anymore. One of the things in the guidelines that people don't realize, people thought it said don't get LDL anymore because there's no goals. Can you imagine not getting LDL? You don't know if they're taking their medicine. You don't know if they're adherent. You don't know if they need another drug, what their residual risk is. It made no sense. And so the ACC expert panel came up with a new term called thresholds. Thresholds are exactly the same as goals, but they wanted to be respectful to the panel and change the name to thresholds. And now we're back to either a 50% LDL reduction or a goal or threshold of less than 70 or 100. It really is not different, and I think this was very wise of the ACC to do because clinicians were bolting and were very disturbed by the guidelines. And so I would just say that, when you have so many people making guidelines, people don't know what to do. And everyone takes their eye off the target. And here I'm saying we all need to come together to agree on a minimal standard of what patients and providers should do, and that no guideline in itself is totally evidence-based. And even though some guidelines use only randomized trials and type 1 and 2 evidence, they still have expert opinion and judgment in it. It's impossible to separate that. So let's get back to the case of that lady that we started with. The black female, 54 years old, had recent NSTEMI, recent PCI and stent. She was on atorvastatin 80. These were her lipids. I don't like her LDL of 128. I don't like her HDL of 48. Should be higher in an African-American female. Should be at least 50 to 60. What is the best evidence-based medicine in today, 2017, on top of a high-intensity statin? I would say, and I just want to show you her pre-treatment LDL, is 187, pretty high, close to almost that LDL of 190 to think of familial hypercholesterolemia. It went down nicely on atorvastatin. Ezetimibe was then added. It went down another 20 points as expected. Again, is that where we want her? I would say if you follow guidelines and you want her less than 70, you're better, less than 100. She's had about a 50% LDL reduction with ezetimibe and atorvastatin. So the current ACC guideline might say you could stop here if you want to. I think very few cardiologists would actually stop at this point. And at this point, we decided to add a PCSK9 inhibitor. It halved her LDL to 45. This lady's never seen LDLs that level unless the date she was born. I mean, most people are born with 30 to 40. She was thrilled because she never had an LDL that low. I was thrilled because I'm saying I think now we can maybe affect her recurrent event rate if we're managing her other lipids. And before I conclude, I want to just say this, that there's a lot of future targets out there, and genetics are really revealing the way. I'm not going to go into other LDLs and Lp(a) related risk, but very strong genetic markers like PCSK9 inhibitors were found. We're seeing triglyceride-rich lipoproteins. You just saw in the New England Journal, ANGPTL4 and 3. This is an inhibitor of lipoprotein lipase. This is very important because triglycerides might be coming back, particularly with ApoC3 mutations. And so I just focused today on LDL and driving it real low. We still don't know about these other lipoproteins. Inflammation. Paul Ricker will have the CANTOS trial presented this summer at ESC using an IL-6 inhibitor. This is fascinating. Will inflammation as a generic target reduce ASCVD? We know inflammation is a marker of risk, but we don't know reducing it, so stay tuned for that. Finally, just something that was in the New England Journal the other day, which I found very interesting. This isn't that citation, but they found this mutation of people with very low LDL, very low triglycerides, very low HDL, happened to be in Pakistan, where there's a lot of intermarriage among first cousins. And they found people who basically were deficient in both alleles for ANGPTL3, and they found that it's compatible with life, people reproduce well. This showed a 35% risk reduction. And so in general, I'm going to conclude with this slide. It's from Brown and Goldstein from their Nobel laureate address in 1986, where they make an argument that they believe that the body needs an LDL level of 25 would be sufficient to nourish the body cells with cholesterol. They might be very prophetic here. We don't know. I think it's a pretty good guess based on the kinetics. But again, lower is better. I'll conclude with this. The clinical data suggests statins are king. They reduce risk in just about every population. with two exceptions, heart failure and dialysis patients. Combination with ezetimibe and PCSK9 have definitely been shown to improve outcome, even driving LDL below the goals of 70. A lower the better strategy clearly is a better way to go because we now have LDL levels safely down to 20 to 30. Combination therapy using new genetic targets, I think, are going to become the hottest thing. I mean, the next PCSK9 mutation, like mutation, the ANGPTL4 mutation, this is the future. And the amazing thing with the PCSK9 story, that it was discovered in 2003 and commercialized within 13 years to a product that reduces risk. It's pretty phenomenal in today's age. Yes, it's a monoclonal antibody, so it's a big molecule, but the future is probably big molecules. But I think the future is very bright for ASCVD prevention. I'd say start earlier and aim for lower goals. I think the data is consistent with that. I think that we can reverse atherosclerotic disease if we could start to control all the risk factors. I'll stop now. Thank you. Woo!
So we're open for questions. Any questions from the crowd here? We've got some nephrologists who want to ask questions.
So what are your recommendations for patients with end-stage renal disease for lipid-lowering agents?
I would say that all CKD patients 3B and 4 are CHD equivalents. Statins have been shown to benefit them. And we have several lines of evidence from SHARP, et cetera. Where there is no evidence is end-stage renal disease on dialysis. We have 2 or 3 negative trials. So I would say I would not wait till they get onto dialysis to use a statin. And just for your knowledge, if you're going to use a statin in CKD patients, atorvastatin is preferred because it has the least renal metabolism. Question.
Hi, Terry. Thanks. We've heard for years about one of the mechanisms of statin being inflammation reduction as well, but you've shown a lot of evidence that LDL is fairly linear. So is LDL the driver of inflammation here, and all of these drugs are likely to also reduce inflammation in the walls?
Yeah, well, this is the whole hypothesis of atherosclerosis, how it starts. But it's, most of us believe in the retention to response hypothesis, where ApoB lipoproteins get in the endothelium, cause damage, and then there's the huge inflammatory response, macrophage response that's not controlled. I think this does blow away the concept of pleiotropic effects of statins. Statins do lower CRP, but it doesn't necessarily mean they reduce inflammation in all populations. I would say 95% of what a statin does is through its LDL reduction mechanism. We can't be sure they do a lot of other things. I'm still puzzled by the amount of stroke reduction that we see because it's not predicted based on the data. Other questions?
Thank you very much, Dr. Jacobson. A quick question about the side effects of PCSK9 inhibitors. I saw a few slides that there was like serious side effects, but do we know exactly, what are the most common side effects? Or is there, for example, any, let's say, additive hepatotoxicity with the statins or?
These are good questions. There is no, actually, as a clinician, the first thing I want to know, is there any more myalgia? Because I just can't take myalgia and statins anymore. It's like 50% of my patients referred. It doesn't affect myalgia. It doesn't affect the liver. In fact, all it really does is cause significant injection site reactions. Occasionally a patient will have a more significant reaction, but we've not yet seen anything. One possible concern, as we've seen with statins, statins have been shown to increase your risk of diabetes, and it's probably causal. And even though it's causal, it's probably insignificant given the amount of risk reduction. there is a lot of genetics that link PCSK9 and insulin and the LDL receptor. And so I'm not sure we're totally out of the woods whether these drugs do not increase one's risk of diabetes. And I think we're just going to have to see longer-term follow-up. But I'm amazed, very safe profile to date. And a big study called Ebbinghaus was just completed looking at neurocognitive instruments, nothing, using very sophisticated instruments.
So I'll just jump in. I thought it was excellent talk. And I mean, this is really obviously a lot of controversy going on. And I thought you brought up some really good points, particularly about some of the other drugs we overlooked, the Zetia addition to statins, early on. I think that's a common mistake many people is not to add that early on. And I think we have a lot to see yet with the PCSK9 inhibitors. I mean, it's, the longer term, lifelong risk, particularly as we talk about treating early in life with diabetes, that cumulative risk over, 4 or 5 decades might be more challenging. The one question I ask you is sort of more of your opinion and probably one of the more common things that people run into, and you talked about the statin intolerant groups. That's probably the biggest problem people run into in the clinic. You have a willing patient and they have myalgias, and whether that's a statin response or just 30 pounds extra on board or whatever. And how do you deal with those patients? And do you believe in the rotating statin theories and things like that? And that might just help people with a pretty routine
Good question.
problem.
This is a huge problem. I mean, it's the biggest reason people stop their statins is either muscle symptoms. Forget LFTs. LFT abnormalities don't really matter. I would say don't even bother measuring them unless you have liver disease. That's how convinced we are how safe. But myalgias are very significant. And generally patients, if they say they have them, whether you believe them or not, they're not going to take their statin. I'm a believer we go through all the statins because I think their benefit is so well proven. It's like taking an ACE inhibitor or beta blocker off the list of a heart failure patient. You're taking mortality benefits away. And so generally, most of us who deal with this a lot can get about 85% on some dose of a statin, but it takes a lot of hand-holding. And so generally, we try a lower dose. We try a different statin. But we will try just about everything. It takes a very long time to do it. Many people will refer patients to me saying, you do it, I'm tired of this. I'm saying, you think I want to do this all day? Yes, I do want to do it all day. This is what I do as a lipidologist. So in general, but there's also what's called the nocebo effect. And you might have heard about this. It's the fear of a side effect. Placebo means, effectively, possible gain. This is fear of getting hurt by a drug. After you've tried a statin 2-3 times, you are phobic about going on a statin. And this is where the psychology and the clinical art of medicine really comes into play, where you basically say, I'm going to give you the safest statin that I have now. And they'll say, why didn't you give it to me before? I said, I just never thought about it. It's a lot of psychology, Bob, and I think we all use it. Some people try other therapies with it, but coenzyme Q10 has not been proven to reduce myalgia. Vitamin D, there's some historical data that people are more statin myalgic with low levels of vitamin D. I don't think vitamin D cures 90% of the problems it supposedly causes. But in general, I would say, work with the patient. Generally, the problem with myalgias is CPK doesn't go up at all. And so it's your word. And so what we generally recommend is stop the statin. If the symptoms go away within 4 to 6 weeks, that's good. Reintroduce another statin. If they occur in 4 to 6 weeks, it's likely that it could be statin intolerance. But if they withdraw it and it doesn't go away, it's in their minds. And I think that I've worked on, with several others, on trying to identify an instrument to detect statin myalgia, and it's very hard. People have so many muscle complaints out there. Get a good history of patients' baseline muscle complaints. I think that is key. On Monday morning, everyone is hurting. I call it Monday myalgia. because they've all gardened, ran their first 10K, played with their grandkids. By Friday, they're chilled and no one's complaining. I think physical activity causes a lot of myalgia, but you can't deny it, and you can't blow off the patient. You have to deal with them head on, but it's the bane of our existence, and I'm sure half of you as well.
Well, again, thanks very much. That was a really great talk. Thank you.